Good afternoon, ladies and gentlemen. This is my case. A 33-year-old male presented with sudden reduction of vision in his left eye on October the 4th of 2017. The visual acuity was in the right eye 612 corrected 66, counting fingers 2 meters with no correction in the left eye, which was the eye he was complaining from. The anterior chamber showed clear characteristics on slit lamp examination. Fundus examination showed exudative macular detachment with mild vitritis, no vasculitis. This was the OCT of the patient, which showed a nearly normal right macula with 290 microns thickness and 973 thick left macula, which was significantly increased in thickness. The senior I presented the case to, or the senior I saw the case with, described the fluid in the left macula as exudative and not serous, which gave us a clue to the diagnosis. This was the B-scan, which shows an exudative detachment in the left eye. The differential diagnosis we put in our minds was inflammatory causes like VKH, sympathetic ophthalmitis, posterior scleritis, or choroiditis, and vascular causes like malignant hypertension, DIC, disseminated intravascular coagulation, wet AMD, and Coats disease. These all were not compatible with the history the patient gave us. He had no previous illnesses. Neoplastic causes like choroidal melanoma, hemangioma, or metastatic lesions should be also put in mind. Atypical CSR was a differential diagnosis that was very possible in the patient. Uveal effusion syndrome was possible, but not very clinically not compatible. Extremely with the case. CNV should be also put in mind, and infections like TB or syphilis. The investigations done for the patient were blood pressure, complete blood count, ESR, C-reactive protein, lipid profile, chest X-ray, or VDRL, and TB skin test. TB skin test was the only one that showed positive results that were useful for the diagnosis. It showed 15 millim in duration, which was considered positive for TB infection in the patient, although he had no systemic symptoms of TB anywhere in his body. The patient was referred for TB treatment to an internal medicine specialist and commenced oral anti-TB combination therapy on October 17, 2017. Followed by prednisolone tab 20 milligrams twice daily. Actually, it was 1 month later. This was a mistake done by me during typing the case. No topical treatment was used for the patient. And this was the OCT after about 2 months from commencing TB therapy. No, I think it was after 6 months of treatment. It showed almost complete resolution, 258 thickness of the left macula. After 6 months of treatment, resolution of the condition almost complete, and anti-TB therapy was stopped on April 16, 2018, to be followed monthly at the time being. The vision finally was 6.9, corrected 6.6 in right eye, and in the left eye it was 6.24, corrected 6.9. The IOP was normal all along. TB can affect any eye, primarily as direct infection or secondarily as a consequence of the immune reaction against the bacilli. Mycobacterium TB is an acid-fast, obligate aerobe characterized by caseating granuloma formation. The choroid is the most common site for ocular TB due to its rich blood supply, high oxygen flow. It may cause any of the following. TB can cause scleritis, flictanulosis, interstitial keratitis, granulomatous anterior uveitis, and iris nodules. The diagnosis is often presumptive after excluding other possible entities, and the definite diagnosis, as suggested by Gotta v. Italia, requires one or more clinical signs suggestive of TB. One of the following ocular investigations needs to be positive: demonstration of acid-fast bacilli by microscope or culture of Mycobacterium TB from ocular fluids, positive PCR from ocular fluids, and because that is always difficult to obtain, the diagnosis of intraocular TB is almost always presumptive, for which Abu al-Asrar Italia and Gopta Italia in their reviews of intraocular TB have put the following definition: ocular findings should be consistent with possible intraocular TB with no other causes of uveitis suggested by history of symptoms or ancillary testing, and there should be strongly positive tuberculin skin test results with 15 millim or more area of induration and necrosis, radiological evidence of healed or active TB lesion in the chest, or evidence of confirmed active extrapulmonary TB either by microscopic examination or culture from affected tissue. And there should be response to anti-TB therapy with no recurrence. Investigations for TB. PPD, purified protein derivative, a positive purified protein derivative skin test indicates prior exposure and not necessarily active infection. Half patients with extrapulmonary involvement may have a negative chest X-ray, and 20% can have a negative PPD test. Also, false negative PPD results occur in 25% of patients at the in immune-compromised patients, and the prior BCG vaccination causes false positives. The quantiferon gold test and interferon gamma release assay IGRA aids the diagnosis of TB and is recommended as an alternative to TB skin test by the US CDC. Because of difficult diagnosis of TB-related uveitis due to complicating factors like prior BCG vaccination, immune suppression, and low yield of aqueous fluid cultures in diagnosis, the use of IGRA test has been found useful in increasing confidence with skin tests when skin tests are indeterminate or inconsistent with the clinical findings. However, negative IGRA doesn't necessarily rule out TB uveitis, and repeat testing may be necessary. This is it. Thank you.